My name is Axel Grothey. I'm a director of GI cancer research at West Cancer Center and Research Institute in Germantown, Tennessee. And I'm excited to talk about updates in GI cancers. So in 2024, we need first talk about immunotherapy for mismatch repair deficient MSI-high metastatic colorectal cancer. This metastatic colorectal cancer, this kind of falls into the category of targeting GI cancers based on their molecular profile. We have various different positive and negative predictive markers in our GI cancers, and mismatch repair deficiency, or MSI-high, is one of them that we need to determine in order to be able to target patients correctly. And it goes through these comprehensive molecular profiling report. Like, this is one of the reports you see here. MSI-high, tumor mutation burden is high because mismatch repair deficiency leads to higher tumor mutation burden, which makes these cancers look different. And that's why the immune system can recognize them when we help the immune system take the brakes off the immune recognition with drugs like pembrolizumab, nivolumab, etc. And that's one of the standards of care to treat metastatic colorectal cancer, mismatch repair deficient MSI-high, was set with the KEYNOTE-177 study, now about 4 years old. Pembrolizumab was compared in first line to chemotherapy, FOLFOX, FOLFIRI-based chemotherapy with bevacizumab and cetuximab. We've seen the data for progression-free survival and overall survival. Here, progression-free survival, you see there is a clear benefit for the use of pembrolizumab over chemotherapy. But you also recognize that the initial phase, in the initial 6 months, chemotherapy might actually be better. So there are some patients who do not respond, where the progression-free survival curve actually drops down below the chemotherapy. And there were some subgroups of patients, in particular the KRAS and NRAS mutant tumors with this study, that did not benefit, even though BRAF V600E mutant tumors did benefit, meaning BRAF V600E identifies patients who are not Lynch syndrome patients with mismatch repair deficient tumors. So whether it was Lynch or non-Lynch, there was no difference. But this study also showed that there was a higher rate of patients with progression of disease compared on pembrolizumab compared to chemotherapy. We still don't know exactly who these patients are. We have not correlated the data with various factors that I just mentioned, including tumor mutation burden, RAS mutation, etc. And could this be pseudo-progression, something that we always kind of ponder in the context of immunotherapy? Now, we do know that patients who do have a response actually benefit quite long. And whenever I have a patient with mismatch repair deficient metastatic colorectal cancer, I believe, these patients are being treated with curative intent. But you can already see there's some room for improvement. So here comes the new Checkmate 8HW study, which compared nivolumab plus ipilimumab, 4 doses of ipi followed by nivo, a single agent, to standard of care or old standard of care chemotherapy in first line mismatch repair deficient MSI-high colon cancer. There was a third arm, nivolumab single agent, which has not been reported yet. Now the question is, how do these data, nivo-ipi combination immunotherapy, PD-1 plus CTLA-4 antibody, compare to the KEYNOTE-177 study with pembrolizumab? And you can see here the progression-free survival looks visually much better, and there's not this initial kind of crossover of curves. And when you now do a PowerPoint experiment, you kind of position the 177 curves onto the slide. You can see it appears to be there's about a 10, 20, 30% improvement for each time point with a combination of nivolumab and ipilimumab. Again, this is not a potentially fair comparison, but just to address the visual difference between these curves. In addition, there was no difference in outcomes, no detriment in patients who had KRAS and NRAS mutations. Even patients who had poor performance status actually benefited. So every single subgroup on this forest plot benefited from the combination of nivolumab and ipilimumab. So what are my conclusions for first-line immunotherapy in MSI-high mismatch repair deficient colon cancer? First of all, we all need to test for mismatch repair deficiency. And now we have 2 options for IO therapy: single agent pembrolizumab or nivo-ipi. And I do tend to use nivo/ipi in patients who can tolerate combination immunotherapy. Even though there is not a direct head-to-head comparison, I think the data are pretty convincing, and it eventually allows for individualized selection of first-line IO therapy. So what about using immunotherapy in early-stage colorectal cancer, mismatch repair deficient colorectal cancer? And there was this in New York Times post, CNN presentations highlighting a very small trial in rectal cancer and talking about a cancer trial, unexpected results, remission in every patient, and do we really need to do surgery? And this was based on a study conducted at Memorial. Andrea Sersik was the principal investigator, and now they've updated their data. They have 48 patients with mismatch repair deficient MSI rectal cancer. And rectal cancer, of course, is critical because some of these patients, if they need surgery, need a permanent colostomy. And, this is something they try to avoid. So these patients received dostarlimab, which is a PD-1 antibody, for 6 months, and they had 100% clinical complete response. This is not they didn't get resection, so they followed these patients, median follow-up 26 months now, and in 42 patients where we have follow-up data, every single patient had a clinical complete response by endoscopy and by imaging studies, and these patients did not need surgery, and none of these patients has yet recurred. And this is very similar to a study we've just seen presented, updated, and published from the Netherlands. So this is now colon cancer, not rectal cancer, but mismatch repair deficient, mainly advanced stage lymph node positive disease, T4 disease. And these patients received 2 doses of immunotherapy, 1 dose of nivo/ipi, 1 dose of nivo, and within 6 weeks, they went to surgery. And you can see here, this is a waterfall plot showing the complete and partial responses. And with only 2 doses of immunotherapy, 98% of patients had a pathological response. These patients went to surgery, so we know what happened with their cancer. Major pathological response, 95%. Pathologic complete response, no tumor visible after 2 doses, 6 weeks of immunotherapy, 68%. And at ESMO this year, they updated the data for disease-free survival. How many patients had tumor recurrence? And none of these patients, and this was more than 100 patients, none of these patients had a recurrence, 100% 3-year disease-free survival. And these are unprecedented data. We would have expected to see at least some patients come back, have recurrence with conventional chemotherapy and surgery, 100% 3-year disease-free survival, 2 doses of immunotherapy. I do believe, this sets a new standard of care. Clearly in rectal cancer, where we try to avoid surgery, and we also know that chemotherapy doesn't work well in these patients. Now, these data look so much better than the data I showed you in advanced disease, where we do not have 100% response, so no recurrence. So why is that happening? It seems to be that the neoadjuvant early stage cancer stage setting is particular prone to, it's particular nice to elicit immune response so that cancer can be eradicated. In colon cancer, NICH2 provides us really with the unprecedented data and shows that every colorectal cancer needs to be tested for mismatch repair deficiency. Now, the question is, will surgeons send us these patients and not take them to surgery first? And who needs to be treated pre-op? But in my clinical practice, particularly when I see a patient with more locally advanced tumor or with frailty and a risk for surgical resection, I favor IO therapy as neoadjuvant or potentially definitive treatment. Now, let's move on to another topic, which I think is very interesting and I feel very passionate about, is the use of ctDNA and MRD testing in early stage colorectal cancer. And you know that circulating tumor DNA, ctDNA, as part of the overall DNA that's circulating in patients' bodies can be used for diagnosis, initial diagnosis, even population screening, detection of minimal residual disease after resection, treatment response to agents, and determination of acquired resistance after treatment. And here in this context, we look at minimal or molecular residual disease. And there are 2 different types of tests on the market right now. It's a tumor agnostic test, disease specific. So these companies develop tests based on, mutational patterns or methylation markers that are off the shelf. So they're not patient adjusted, but they only work in, let's say, colorectal cancer or breast cancer. So you have tumor specific tests like Reveal and XMRD from Tempus and Garden, respectively. And they are easy to use because, you just use them like a tumor marker. Then they're tumor-informed disease agnostic tests, meaning the patient's tumors gets profiled, and there is a certain mutational pattern that is detected in patients' primary tumors, and then a specific PCR test is being run on patients' blood after sequencing. That's the Signatera haystack personalis test, that we use in our clinical practice. So it's a very personalized test. So you can use it in colon cancer, in breast cancer, in bladder cancer, based on, again, the individual mutation profile. Logistics more complicated because it takes longer to get the first test developed because the tumor needs to be profiled. Now, the whole arena of MRD testing was kind of broken into by Jane T's, study about 8 years ago now, where she showed that patients who had ctDNA positive after tumor resection in stage 2 colon cancer, all of these patients had a recurrence within the first 3 years. So there was a big difference in outcome between ctDNA negative and ctDNA positive patients. And this led to various large international clinical studies. And I think leading the way right now is Japan. Japan, and this is a complicated slide, puts ctDNA analysis, personalized ctDNA analysis, tumor-informed tests into the whole spectrum of care of colorectal cancer. And they have reported out so far the error-based, the little error that I put on the right-hand side, the Galaxy study. The Galaxy study is a study where they looked at stage 2 and 3 colon cancers, colorectal cancers, and they do sequential blood draw ctDNA testing once in the MRD window between 4 to 12 weeks, where two tests within 4 and 12 weeks, where we make decisions for adjuvant therapy to see, do we need adjuvant therapy in these patients? And the second is the surveillance windows over the next years of patients' care after a colon cancer resection. And they've seen, for instance, here, a new publication just 2 weeks out in Nature Medicine, disease-free and overall survival based on ctDNA positivity and negativity in the first part of the MRD window between 4 and 12 weeks after surgery. There's a big difference in disease-free survival and overall survival, highly statistically significant, whether patients have positive ctDNA or not. And the same is true for when patients are positive or have DNA positive in the surveillance window, over the years of, following these patients. Clearly a highly prognostic marker for patients, whether or not they're positive. You see the curves are very, very far separated for disease-free and overall survival. And when you put these ctDNA results into a multifactorial regression model, meaning you see what factors really contribute most to outcome for disease-free survival, it is very clear that on the right upper hand corner, ctDNA positivity is the most dominant, the most important prognostic factor. And the second most important prognostic factor is mismatch repair deficiency, MSI, because these patients do better because the immune system can fight these tumors off. T and N stage are not as important as the ctDNA in the MRD window. Now, very provocative data here. Do patients benefit from adjuvant therapy? On the left-hand side, you see patients who had mismatch repair deficient positive tumors. You can see with the use of adjuvant chemotherapy, the blue curve, compared to just observation, no treatment, there seems to be some difference. The data are not strong enough because they're small numbers, but there is at least a separation in curves. On the right-hand side, you see patients who are MRD negative, meaning after surgery, there was no circulating tumor DNA detected. And at least from these data here, there does not seem to be a real benefit from adjuvant chemotherapy compared to observation. These are not randomized studies. These are observational cohort data. So they would need to be validated over time to see, can we really not give adjuvant therapy in patients who do not have ctDNA after surgery? Now, the one thing is also, some patients have a transient clearance, meaning when you have adjuvant therapy, patients might have no clearance, meaning no clearance of ctDNA, that's the red curve, a transient clearance, it went down to 0 and then came back. and or sustained clearance if ctDNA stays away over time. You can see there's a big difference in outcome in disease-free survival between these different patient populations. Sustained clearance is really the way where we like to see. Transient clearance gives some disease-free survival benefit, but these patients apparently are not cured. So the presence of ctDNA means there's something going on. Patients are not yet free of disease. Now, my conclusions on ctDNA in early stage, it is clearly the most important prognostic indicator to date, more important than TNM tumor stage, and conversion from positive to negative ctDNA can be achieved with systemic chemotherapy, and that's the important point, and it does have DFS benefit. I saw you, the sustained clearance really gives patients a chance to be cured. ctDNA positivity can make a decision for adjuvant therapy in settings where we normally would not do therapy, like stage 2 colon cancer, low risk. I have patients who have a clinical low risk stage 2 colon cancer, but ctDNA is positive. First of all, we do PET scans to see, can we find the source of the ctDNA? Sometimes it's liver metastasis, but then I would give adjuvant therapy to give patients to clear the ctDNA. Withholding adjuvant therapy, even when you look at the data that we just see based on a negative ctDNA test, it's a little bit more risky because you don't want to kind of miss out on benefit for patients. That's currently being tested in prospective clinical trials that we at West Cancer Center also participate. Lung metastasis, interesting, a blind spot of current ctDNA tests. There's still room for improvement, and new tests are coming to the market. Now, let's talk about a new standard of care in distal esophageal and gastroesophageal junction cancers, a plenary session presentation at ASCO this year. This is a German study, perioperative chemotherapy with FLOT, 5-fluorouracil, oxaliplatin, and docetaxel versus the old chemoradiation therapy crossed with carboplatin and paclitaxel as radiation therapy for resectable esophageal adenocarcinoma, the so-called ESOPEC trial. And until the study was presented, for the higher risk tumors, the low two lines of the slide here, T24 and plus or minus, neoadjuvant chemotherapy, a perioperative chemotherapy plus surgery, the European standard, or neoadjuvant chemoradiation therapy followed by surgery were both considered standards of care. And this study now compared these two different worldwide standards of care, FLOT versus CROSS. So chemotherapy alone, perioperatively, 4 cycles before surgery, 4 cycles after surgery, to the probably American standard of neoadjuvant chemoradiation therapy, using a radiation dose which is probably a little bit on the lower end, 41.4 Gray. Here at West and other centers, we use 50 Gray for adenocarcinomas. But all these patients had surgery. The primary endpoint was overall survival, adequately powered, 440 patients, and including criteria. These were adenocarcinomas. They're really the distal esophageal adenocarcinomas that we normally use radiochemotherapy for, no metastatic disease. And these are the outcomes data for progression-free survival. You see that the red curve, just chemotherapy, perioperative chemotherapy, no radiation therapy, was clearly superior in progression-free survival compared to the radiochemotherapy. And for overall survival, again, highly statistically significant difference, 3-year overall survival rate difference of about 7%. Clearly, FLOT perioperative chemotherapy was superior to the cross regimen. And interestingly, even, all patients were supposed to go to surgery, there was a higher rate of pathologic complete remission, 17% compared to 10%, even though the local effective radiation therapy was not present in this one patient population. So why is that? From data from the CROSS study, the radiochemotherapy study, we've already seen when you compare on the right-hand side, this is now the CROSS trial, surgery alone versus neoadjuvant chemoradiation therapy. The CROSS really worked on local regional and local regional plus distant recurrences, but the pure distant recurrences were not affected, meaning 28% of patients with surgery alone and 27% of patients with chemoradiation therapy had distal metastases as signs of recurrence. And this is really the chemotherapy component of the cross regimen. Carboplatin and paclitaxel was probably too weak, and FLOT is better and can prevent these distant recurrences in some patients. Now, one point that we've not talked about is what about immunotherapy? Because in the setting of cross-regimen with patients who use chemoradiation therapy, one of our standards of care is actually to use additional nivolumab after resection in patients who still have some tumor presence, either as, in the primary tumor or lymph nodes. And this, again, is in context of chemoradiation therapy. We don't have these data now for the FLOT study. So what are we going to do? Should we use nivolumab as part of the additional part of the perioperative therapy when we use FLOT? So AZOPEC does set a new standard of care for patients considered for chemotherapy with a triplet regimen. Median survival improved by 29 months. We probably treat micrometastatic disease early. It appears to be important to do that. There's an interesting local therapy effect because the pathologic complete response rate is higher with chemotherapy compared with chemoradiation therapy. But as I said, the radiation dose is not optimal for adenocarcinomas. There are some patients where we actually do not want to take them to surgery. These were all patients that needed to go to surgery because some patients were frail, some patients are frail, and we use a definitive treatment upfront for these patients. So could radiochemotherapy still be a part of our definitive treatment? And of course, the mismatch deficient gastroesophageal cancers, they also need different treatment. And there's data that these patients also respond to immunotherapy. I also mentioned that Checkmate 577 defined adjuvant immunotherapy, nivolumab after chemoradiation therapy, as alternative, as one of the standards of care. So we don't have these data with immunotherapy added to this whole treatment sequence for the FLOT study. So should we consider adjuvant immunotherapy after perioperative FLOT? If no pathologic complete response is achieved, these are data which we just don't know. And with that, I'll thank you for participating on this ride, being on this ride through the new data on GI cancers in 2024. Thank you.